Okay, so all the speakers, please be in the time because we're running the short of the time. So our next speaker is Dr. Junaid Babar from the Genoa Hospital. He's going to talk about the primary PCI of Degenerated Venous Graft. Dr. Junaid Sharaf. With a 5 minutes presentation and 5 minutes to comments. So please be in the time.
Bismillah ar-Rahman ar-Rahim. Starting with the name of Allah, the most beneficent, the most merciful. I'm Dr. Junaid Babar, working as postgraduate resident in cardiology department in Hospital Lahore. The topic for today's case is primary PCI of venous graft. Starting with the case scenario, a 68 years old male with well-controlled diabetes presented with typical chest pain and sweating. He underwent CABG in 2006. He had left atrial appendage clot. He was on single antiplatelet and rivaroxaban. He was on routine follow-up. His graft study was done in 2012, which showed degenerative changes in SVG to diagonal and no significant obstructive lesion. This is the ECG of that patient, showing ST segment elevations in the lateral leads. The patient had ongoing chest pain, so we decided to proceed for primary PCI. This is the coronary angiogram showing dominant circumflex with no significant obstructive lesion, and there is retrograde filling of SVG to circumflex and totally occluded LAD. Non-dominant small caliber RCA with moderate proximal disease, and the stump of totally occluded SVG to diagonal. Lima to LAD was patent with mild disease in the native vessel after the incision, and there is retrograde filling of diagonal through Lima to LAD. So how to proceed further? The options were anticoagulation, thrombolytic therapy, and PCI of totally occluded degenerated venous graft. Since the patient was having ongoing chest pain with ST segment elevation in the same diagonal territory, so we decided to proceed with PCI of totally occluded vein graft. We took 2 into 12 mm semi-compliant balloon, and the pre-dilatation was carried out, which showed some restoration of the blood flow. Then we pre-dilated with 3.5 into 12 mm non-compliant balloon, TME1 flow in the distal SVG with heavy clot burden. We gave intracoronary drug, which include the tyrofeban boluses, nitroglycerin boluses, adenosine boluses, saline flushes, and adrenaline boluses. Later on, we took 4 into 38 millimeters Promus premier stent and deployed it and inflated at 12 atmospheric pressure. As you can see that there was no flow. The distal lesion was stented with 4 into 16 mm stent by overlapping the distal edge of the proximal stent. As you can see in the previous slide, there was contrast hanging and sluggish distal flow. Meanwhile, the patient started having chest pain and became hypotensive. What to do next? So we took export advanced aspiration catheter and causing aspiration of the clot, while we use the same aspiration catheter for the distal drug delivery. These were the final results with good expansion. So, hospital course was the patient remained on tyrofeban infusion for the next 24 hours. He made uneventful recovery and was discharged successfully in next 48 hours. Post-procedure echo showed mild LV systolic dysfunction. He's currently on aspirin, clopidogrel once daily, and rivaroxaban twice daily. He's on regular follow-up and is currently symptom-free. So the learning points include SVG lesions with thrombotic occlusion are considered high risk. Complications include no flow, abrupt closure, distal embolization, and perforation. According to the latest American Heart Association guidelines, in selected patients, embolic protection device is reasonable to use in SVG intervention, which is considered as class 2A indication. Previously, it was class 1, now it is considered a class 2 indication. Atherosclerotic plaque in SVG are more diffuse, with thinner, more friable fibrous caps that increase risk of distal debris embolization. Liberal use of aspiration thrombectomy may salvage a thrombus-laden graft. Thank you so much.
Junaid Babar, finished in time. Only 2 comments by Dr. Mansoor and Dr. Bashir.
I want to know the indication of SVG intervention. As one is stable ischemic heart disease and other is the ACS. Your patient was ACS. The indication of 2B3A inhibitor as you given in this patient. What was the indication of 2B3A inhibitor in this patient as you given in this patient? And initially, as you wired the patient and there was no TIMI-2 or TIMI-3 flow and you stented this patient. So what was the strategy stenting a patient without having TIMI-2 or TIMI-3 flow?
I'm Dr. Ahmed Mukita. I'm Dr. Assistant Professor of Cardiology at Junaid Hospital, Lahore. I was supervising this case with Dr. Junaid. And a very good question regarding the use of GP2B3A receptor inhibitors, tyrofeban. The routine use according to latest ACC/HA guidelines in SVG PCI is not recommended. But in this case, there was heavy clot burden, and secondly, there was extensive no flow. And the use of tyrofeban was for these indications in this patient. And what was the second question? Yes. Stent, regarding stent, yes, we achieved the TIMI 1 to 2 flow, but again, we had his previous graft study done about 5 years ago, which showed that the distal vessel was SVG was almost about 4 millimeter size, and the clot was there was heavy clot burden. And we wanted to just achieve the flow distal, and we thought that it might help with stenting the lesion and squeezing the clot over there.
Okay. Any other comment by Dr. Mansoor?
These days, use of filter is much less. I remember using filter every time I did SVG, particularly the shaft. And these are difficult things, so it can happen anywhere. But the question is that about the stenting when there was no flow. But anyway, you retrieved the patient very well. It was wonderful.
Thank you. Dr. Aminul, I have one question. You did an aspiration after the NC balloon. What is the need? Why you didn't do the aspiration before the NC ballooning? Because you pre-dilated with the NC balloon.
Yes. Again, the thing is that when we stented it, and then again there was severe no flow, almost TIMI 0 flow. Then we delivered the drugs through the guiding catheter, including all the drugs recommended for the no flow in recommended doses, but nothing worked. Then the only thing that worked was this aspiration of the catheter, and we aspirated the clot. It was fresh clot. The picture was not shown over here, and that the same export catheter was used for as a macro catheter for distal delivery, drug delivery. And with after aspiration, the flow was restored, and it was a patent vessel.